afternoon and welcome. Today, Bariatric Advantage is sponsoring this webinar that's going to discuss a very interesting topic. We're going to hear about a novel probiotic that has been implicated in assisting weight loss and assisting weight maintenance, and this should have terrific opportunities in our bariatric practice and in assisting our severely obese patients. I'm Dr. John Dixon from Melbourne, Australia. I head the Clinical Obesity Research Group at Baker Heart and Diabetes Institute, and for the last 20 years I've had a major interest in all aspects of better managing our patients with severe obesity. Before we commence our program on this exciting new probiotic, I want to cover with you a few housekeeping items to allow the best presentation, the best experience of this presentation. At the bottom of the screen there are multiple applications or widgets. They look like little icons. They can be moved around, resized, and put in spaces that are convenient to you. We will be addressing questions at the end of the webinar, so please submit questions during the course of the presentation. We will try and answer those questions at the end of the program, but some may not be dealt with, and they can be addressed via email later. A copy of today's slides and the key study will be available on the resource list. For the best viewing experience, we recommend using a wired internet connection, closing any programs or browser sessions that are running in the background that could cause issues. Webinars are bandwidth intensive, so closing any unnecessary browser tabs will help conserve the bandwidth. Webinar is being streamed through your computer, so there's no need for a dial-in number. For best audio quality, please make sure your computer speakers are turned on and the volume is high so that you can hear the presentations. Some networks do cause the slides to advance more slowly than others, so logging off your VPN is recommended. And if your slides are behind, pushing the F5 button on your keyboard will refresh the page. You can find additional answers to some of the technical questions located in the Help widget on the bottom of your screen. An on-demand version of this webcast will be available in approximately 1 day, and the access to this link will be the same one that you've been sent earlier.
Today I'm accompanied by two guests. First, Dr. Alvin Abira is a food technologist and scientist with a broad experience in clinical development of nutraceuticals and functional foods. Dr. Abira is the author of several peer-reviewed scientific publications and holds patents related to functional food ingredients. Currently, Dr. Abira holds the position of Clinical Trials Director at DuPont Nutrition and Health, based in Kantvik, Finland. He's tremendous experience in functional foods, probiotics and prebiotics, and he will present the preclinical and clinical data of this novel probiotic. My second guest is Dr. John Morton. Dr. John Morton is a bariatric metabolic surgeon who will be known to many of you. He's a past president of the ASMBS, and he's chief of bariatric minimally invasive surgery at the university at Stanford University School of Medicine. He has a tremendous interest in the breadth of fields related to obesity and bariatric metabolic surgery. He has a special interest in nutrition and in particular the use of probiotics regarding bariatric metabolic surgery. So he'll be invaluable in our discussions later. So our program today is going to discuss clinical issues of obesity, the challenges of weight loss, and particularly weight loss maintenance. We all understand the challenge of weight loss maintenance is in bariatric medicine and bariatric surgery. This is a great difficulty, and any tools that can help us maintain the weight that's been lost are tools that we should seriously consider. We need to further understand the link between the gut, intestinal microbiome and body weight regulation, in particular the potential for altering the microbiome to help with weight loss and help with weight loss maintenance. We need to learn, today we'll learn about Bifidobacterium lactis B420 and how it may be able to help in body weight loss and maintaining weight regulation in the long term. In addition, how we might potentially integrate this probiotic B420 into clinical practice guidelines for our patients. It's an area that we really need to explore for its potential in the future. Without further ado, I will hand over to Dr. Alvin Abira, who is going to provide the preclinical and clinical data regarding B420.
Thank you, Dr. Dixon, for the introduction. Indeed, the prevalence of overweight and obesity worldwide is shocking, especially in the U.S., the leader among the 10 top countries that encompasses more than half of the obese population in the world. Our current sedentary lifestyle has made obesity an epidemic, especially in the industrialized world, leading to many diseases associated with high fat mass. During the last 2 million years of evolution, we have been fighting to get food, and only during the last 200 years of industrialization, humans have had excess food supply. Unfortunately, we don't have mechanisms to reject excessive energy consumption. As we can see, despite benefits of weight loss to overall health, only 1 in 6 overweight or obese American adults report ever having successfully maintained weight loss of at least 10% for 1 year. Certainly, reaching a healthier weight and weight maintenance are difficult, especially in longer term. As you can see in these examples, only 1 in 12 men and 1 in 10 women with simple obesity are able to lose 5% of body weight over a 9-year period. Likewise, the weight loss values are somehow similar in morbidly obese individuals. Unfortunately, it is extremely challenging to maintain weight loss during long periods of time. The odds of attaining normal weight are very low. It is about 1 in 200 for obese and 1 in 1,000 for morbid obese. Evidence shows that about 85% of obese regain weight eventually. There is substantial evidence indicating that weight is gained with age, which is in accordance with epidemiological evidence showing that the worldwide population is getting obese. In this example from Lohmann and collaborators, we can see that about 30% of the normal middle-aged Finnish population gained 11 pounds over a follow-up of 5 to 7 years study period in both men and women. This is a reality in almost all industrialized countries. Whereas previous studies were focused on non-surgical populations, these patterns of body weight regulation are also relevant to surgical population. It is well accepted that bariatric surgery is very successful in inducing body weight loss for vast majority of patients. However, after an initial honeymoon period during the first 6 to 12 months, where body weight is steadily decreasing, a pause in weight loss may occur with further weight regain. This is of a special concern for many patients. This slide presents data from the longitudinal assessment of bariatric surgery cohort, which clearly shows different weight trajectories in post-surgery periods. Among the majority of patients with Roux-en-Y gastric bypass who were successful in losing weight, there is a subgroup who regains weight from 6 months onwards, here shown in orange. In fact, all groups tend to regain some weight eventually, and in some cases reaching a body weight gain higher than the initial weight prior to surgery. Obviously, there are many factors involved in this process, but it highlights that all patients need long-term support, and some of them need even more intensive support. Dr. Jan Morton, who will take over after my presentation, will discuss more in depth about the importance of the use of probiotics in bariatric surgery for weight maintenance. Recent evidence strongly indicates that microbiome plays a pivotal role in the regulation of body weight. In this study from Ria Dura and collaborators, published in Science in 2013, we can observe the effect of fat mass change caused by fecal microbiota transplant from lean and obese twins to germ-free mice. In this particular study, a 15-day post-colonization with microbiota from the obese twin increased the fat mass by 10% in mice, while mice colonized with microbiota from the lean donor didn't change in fat composition. As evidence from the animal trial indicates, the obese phenotype can be directly transferred via the microbiome in humans. Indeed, several meta-analyses and individual studies indicate that there are clear differences in the microbiota from lean and obese individuals. Just to give you an example, lean people present higher number of bifidobacteria, lactobacilli, and specific species such as Fecalibacterium prausnitzii and Bacteroides tetaiotau-micron, which increases short-chain fatty acids and protects against chronic inflammatory diseases. On another hand, obese people present higher number of other kind of species such as Clostridium, which in turn is associated to chronic diseases. It is also important to highlight that obesity is associated to a less microbial diversity. Overall, beneficial microbes associated to weight regulation show characteristical expression pathways related to increased energy harvesting, production of short-chain fatty acids, and barrier function improvement. Although the diversity of the microbiota is important, strain specificity plays a key role on its efficacy. Just to give you an example, let me talk about dogs. As we know, all dogs belong to the same species of Canis lupus, but it is not the same to go out jogging 5 miles during the weekend with a golden retriever than with a chihuahua. The same happens with probiotics. A number of studies in literature show that strain specificity determines efficacy, and therefore research must be conducted with well-characterized species. Several years ago, we started a research program screening for potential probiotic candidates to help regulating body weight and composition. Among the best candidates was the probiotic that we will discuss today, Bifidobacterium animalis subspecies lactis B420, which is commonly known as B420. In a nutshell, the research program, which included in vitro, animal, and a recent human clinical trial, showed that B420 improves gut barrier function and metabolic health and contributes to body weight regulation. As mentioned, our research program on B420 generated several results at in vitro and in vivo levels. In vitro results demonstrated that B420 increases tight junction integrity. Animal studies have shown that B420 adheres well to the intestinal mucosa in fat-induced models and improves the animal's overall inflammatory and metabolic status. One of the most striking results from the animal studies is shown in this slide. As you can see in the left figure, black 6 mice fed with high-fat diet plus B420 reduced weight gain as compared to the high-fat diet group alone. The right figure shows that before 20 markedly prevents the increase in fat mass, while it doesn't affect the lean mass composition. Here we can see the study design of the clinical trial to study the effects of before 20 in overweight and obese. This was a randomized, double-blinded, placebo-controlled, and parallel study conducted in 4 sites located in Finland. The intervention took place between December 2013 and May 2015. 225 overweight and obese, but otherwise healthy males and females were included, with a BMI ranging from 28 to 34.9. Participants were equally distributed to one of the 4 arms, which consisted of a microcrystalline cellulose control, 10 billion colony-forming units of before 20, 12 grams of lactase polydextrose as a dietary fiber, and a combination of 12 grams of lactase and 10 billion colony-forming units of before 20. Participants added the investigational products in a provided commercial smoothie and drank it daily during 6 months. Participants attended study visits at baseline and after 2, 4, and 6 months of intervention. There was also an additional follow-up visit without treatment 1 month after the end of the treatment. The primary outcome was relative changes in body fat mass, and secondary outcomes included body composition, anthropometric measures, and dietary intakes, as well as markers of endotoxemia and bacterial metabolites. The study followed strict good clinical practice procedures, and the trial master file is deposited at the DuPont Nutrition and Health Archives in Kamvik, Finland, for a period of 15 years. This diagram explains the study populations as defined during the blind data review process. Out of the 225 participants randomized, 16 were excluded from the intention to treat population because they drop out before the next visit and the 2nd month of intervention. Out of the 209 participants included in the intention to treat population, there were 75 excluded due to non-compliance with the protocol, for reasons like consumption of antibacterials, for example. Therefore, the database was locked after the blinded data review with 209 participants in the intention to treat population and 134 in the per-protocol population. The data from both intention to treat and per-protocol populations were analyzed following the predefined primary analysis and also with a post-hoc factorial analysis. The predefined primary analysis on your left consisted of an ANCOVA in order to determine if there were differences among treatments, considering baseline values as a covariates. In case there were significant differences between treatments, a multi-comparison analysis using the Dunet's test was conducted. The Dunet's test allows to compare individual treatment against one of them, in this case the placebo. The factorial analysis on your right allows to group the effects of before 20 or the dietary fiber, taking advantage that there was one treatment that combined the 2 products. Thus, we can estimate the overall effect of before 20 or the overall effect of the dietary fiber. This slide shows the results of body fat mass, the primary outcome of the study. ANCOVA results are presented in blue on the top figures and factorial analysis results in red on the bottom of them. As you can see, the patterns in the intention to treat and in the per-protocol populations are similar. However, significances are reached in the per-protocol population, as it is more consistent with the study design. In the per-protocol population, the ANCOVA analysis tends to significance. The Dunet's test indicates that the combination of B420 and dietary fiber is significantly different from placebo, inducing a reduction by 1.4 kilograms in fat mass. In fact, the factorial analysis confirms that the significant effect in reduction of total body fat mass is due to B420. Considering the overall effect of B420 in the factorial analysis, the reduction in body fat mass represents 1.4 kilograms, equivalent to a reduction by 4% as compared to the placebo. Remarkably, out of the 1.4 kilograms reduction in fat mass, 1.2 kilograms, representing 86% of it, were lost from the trunk. Like for the overall fat mass reduction, according to the ANCOVA and the factorial analysis, this effect is largely caused by B420. As we know, metabolic syndrome is associated with abdominal obesity, blood lipid disorders, inflammation, insulin resistance, and increased risk of developing cardiovascular disease. The presence of metabolic syndrome alone cannot predict global cardiovascular disease risk, but abdominal obesity, which is the most prevalent manifestation of metabolic syndrome, is a marker of dysfunctional adipose tissue and is of central importance in clinical diagnosis. A high ratio of waist to hip circumference, what we call the apple shape, has been shown to be associated with a high proportion of intra-abdominal fat. The metabolic complications of obesity, which are associated with a high ratio of waist to hip circumference, may therefore relate specifically to the amount of intra-abdominal fat. Many have proposed that abdominal obesity, measured by waist circumference, is even more accurate predictor of cardiometabolic risk than general obesity measured by body mass index. In this sense, the effect of B420 in reducing waist circumference is of particular relevance. In our clinical trial, the overall effect of B420 represents a reduction of 2.4 centimeters or 1 inch as compared to the placebo. In this figure, we can see the evolution of total body fat mass during the study. It facilitates to understand that a reduction in fat gain is associated to the B420 treatment alone, here marked in green, and to the combination of B420 with a dietary fiber, marked in blue. The effect in reduction of body fat mass induced by B420 was maintained 1 month after the treatment period was completed. Body weight was one of the secondary outcomes of this study. In this figure, you can observe that body weight tends to be reduced by the B420 group. The factorial analysis indicates that B420 exerts a significant reduction in body weight after 6 months of intervention in those participants who had high adherence to our protocol. During the research program, we observed that B420 increases the production of short-chain fatty acids, an effect that is linked to the modulation of satiety hormones. Regarding the dietary fiber used in this study, like Lactase Ultra polydextrose, we already had substantial evidence from animal and clinical trials indicating that it regulates gastric peptides, especially GLP-1, and reduces energy intake at subsequent meals. Accordingly, in the clinical trial, we observed a significant reduction in energy intake after 6 months induced by B420 and its combination with a dietary fiber. The reductions in energy intake here observed, of approximately 250 kilocalories per day, are in agreement with observed effects in reduction of fat mass. Therefore, reducing calorie intake, possibly due to appetite suppression, might be one of the mechanisms associated to B420, but this observation requires further research. It is important to highlight that this study didn't include modifications in dietary habits or physical activity. For example, the figure here shows that there were no differences in physical exercise. Therefore, the results from this clinical trial can be attributed exclusively to the effects of the investigational products alone, which is of special interest from the research point of view. However, the products here studied, B420, Dietary Fiber, and their combination, should be provided to consumers in a context of healthy lifestyle, promoting the improvement of dietary habits and physical activity. The prevalence of obesity is a very complex problem that requires a multidisciplinary approach. From the safety point of view, there were no major differences in reported adverse events across treatments, as you can see in this table. Over the course of the study, 189 participants reported at least one adverse event, out of which 133 were potentially product-related in opinion of the investigators. Potentially related adverse events were mild and short-lived. For instance, the median duration of the cases of diarrhea and loose stools was only 3 days. Overall, the number of adverse events observed are typical of this kind of study design and length. In addition, there were no changes in measured safety parameters such as systolic and diastolic blood pressure, heart rate, and liver enzymes, as you can see in this table. Therefore, we can conclude that the study products were well tolerated and that there are no major concerns about their safety. As a summary of the clinical trial, we can conclude that B420 and the combination of B420 and dietary fiber have weight management benefits by reducing body fat mass, trans fat mass, waist circumference, and energy intake as compared to the placebo. The potential mechanisms of action associated to the effects of B420 in controlling body composition can be summarized in this figure. B420 has a beneficial modification in the gut microflora, decreases the mucosal adherence of pathogens, and enhances epithelial barrier function. The observed effects of B420 in increasing short-chain fatty acids production might be linked to a positive modification in satiety hormone levels. Confirming this mechanism will require more research, but evidence in this clinical trial indicating that B420 alone reduces energy intake points in this direction. To conclude, I want to highlight that there is an increased evidence in the scientific community linking the intestinal microbiome with regulation of body weight and body fat mass. The research program of B420, which covers in vitro, in vivo, and the presented clinical trial, show that it has a beneficial impact in the intestinal barrier function, regulates energy intake, and positively affects body composition and body weight by reducing fat mass. Finally, I would like to thank all the team who participated in this clinical trial, especially to my colleague Lotte Steinman, who was the clinical study manager. Lotte is happily on maternity leave and could not attend to this presentation today. Now please let me hand over to Dr. Jan Morton, who will discuss about the importance of the use of probiotics in bariatric surgery. Okay, Dr. Morton, the floor is yours.
Well, I want to thank Dr. Barra for that wonderful presentation. I think it's unique that we get to hear about this kind of research early on. I'm John Morton, as you've heard earlier, and past president of ASMBS, American Society for Metabolic and Bariatric Surgery. And this is a topic that's been of interest to me for probably over the last decade. And I think we're seeing a lot of changes within our microbiome. We're having better understanding of what happens with the microbiome. And I think this study helps underscore that. If you think about it, how is our microbiome changing? And we're actually undergoing a lot of influence and change in our microbiome, mainly through all the antibiotics that we prescribe to patients. That can disturb the kind of microbiome that we have. We know this from actually animal studies or just raising animals. For many years in the United States, farm animals were given antibiotics to increase their weight. Farmers knew this a long time ago. If you give antibiotics, it will make people gain weight. It will make the animals gain weight. So that's a place that we're seeing some of these changes take place. A lot of antibiotics are maybe changing our microbiome profile. And the big question that comes to mind is, how you can restore it. And I think this particular probiotic is very interesting to see how it can help restore us hopefully back to a more natural weight. The other reason I'm interested in it, coming from bariatric surgery, is if you look at how the probiotic is consumed and how it's related to the microbiome, it has to traverse the stomach, which sometimes is a hostile environment. But as we all know, with bariatric surgery, either you reduce the stomach or bypass it entirely. So this is a nice opportunity to introduce the probiotic. A few years ago, we did a study looking at the use of probiotics in patients, and we found that patients who took them actually lost a little bit more weight than patients who did not take them. We also saw less bacterial overgrowth, and we saw an improved GI quality of life. And finally, one thing that was really interesting was that some of these patients had more vitamin available after the use of the probiotic, which can be explained in part to some of the bacteria that do utilize the vitamins for their own substrate. What's really interesting about this study, though, is the fact that they were able to demonstrate such an improvement in patients before and after with the use of the probiotic. I know there's still some questions that remain about this, but I will say one thing that's for sure is that the risk-benefit profile for probiotics, and in particular B420, is quite good. The risk is low, and I think there is an opportunity here to have some improvement. And as you guys saw in the presentation, it was a well-designed study, over 200 patients, and these were lower BMI patients. So I think there's opportunity to see how this works with even patients who are even heavier. And in the end result, as you saw there, patients not only lost weight, they ended up having almost an inch of reduction in their waist circumference, and a lot of good things that occurred with it. This may not be the entire answer, but it certainly is a start. And I know there's a lot of questions that are associated with the microbiome and weight gain and probiotics in general. And I can't think of a better person to discuss some of the questions that might come up around this, and hopefully the three of us can provide some answers. I think Dr. John Dixon, who's head of clinical obesity research at Baker Institute in Melbourne, is an ideal person to discuss this, as you already heard earlier. He is extremely well recognized internationally for all of his efforts around obesity research, and again, he's the ideal person to help lead us in discussion here around this particular presentation and weight loss and probiotics in general. So John, I think you're on the call as well.
Yes. Thanks very much for the introduction. You're absolutely right. I think anything that helps us attain weight loss and particularly maintain weight loss is very attractive. I want to recognize that, in fact, weight regain following weight loss is normal, natural, physiological, and expected. And we've got to understand that bariatric surgery, along with any drugs and other things that are programs that are effective actually have to continue working indefinitely, and we desperately need every tool we can get our hands on to treat this serious disease. And of course we see the hard end of this serious disease. So to be able to add another tool to our toolbox for managing obesity, managing the metabolic problems, is absolutely vital. And I think when I think of probiotics, prebiotics, the microbiome, and the future, I see a very bright future. What I'm saying is the potential for this whole area altering the microbiome, altering the gut health, the metabolic health, as well as weight, are great opportunities in the future. I think there are a lot of questions though, and I'm sure that the audience will have questions regarding this, and please type them in. But I have some specific queries. One, I suppose, John mentioned a moment ago about the probiotics in general and their safety and efficacy. But I'd like to ask Dr. Ibira about the specificity of probiotics, the specificity for their effect. Here we've got B420 having quite specific effects on tight junctions. It's having an effect perhaps through GLP-1 on appetite, but the opportunity for being specifically therapeutic. Dr. Ibira, would you like to comment on the specificity?
Yes. Well, during the development of any probiotic, specificity becomes, probably one of the most important, factors. Because, for instance, in any kind of research platform, you always start with several probiotics as potential candidates. When we started this specific research program, we went over perhaps more than a couple of dozens of already selected probiotics with, potential in vitro. So the first, hypothesis was to test the capacity of the probiotics to support barrier function in the intestine, because the hypothesis during that time, I'm talking about 10 years ago, was that if we were able to enforce barrier function, we will be also able to reduce inflammation, and inflammation will be related, anti-inflammatory effects will be related also to metabolic disease. So we discovered that, among several probiotics that we were testing, only few of them were able to, improve barrier function. And then we also saw that some of them were able to produce more short-chain fatty acids than others. And these short-chain fatty acids were also related to the, for instance, production of gastric peptides. So it's really a long process, and you find out that not all the bifidobacterium are working exactly in the same way. Not all of them are really the best candidates. And then it's let's say normal process then when you go to animal trials that we ended up perhaps with 3 to 4 candidates. And then finally we went with these B420 to the human clinical trial, and effectively, we observed really good results in the reduction of fat mass in time, preventing the increase in fat mass and regulating body weight. So just to conclude, specificity in species, subspecies is extremely important in the development of probiotics.
Dr. Abira, thank you for that detailed answer. In fact, a couple of questions have come through that really relate to this, and one is, what foods do you recommend that contain this probiotic, and the other, is very similar in suggesting that how do we get this as a natural probiotic? Is this a natural probiotic, or is this a designer probiotic, and are we looking to the future in using designer probiotics?
I mean, all the probiotics are natural. They are always isolated from basically feces or some food products. So in that sense, they are natural. I mean, we are not doing genetically modified microorganisms in the development of probiotics. I think that in general, I mean, all the industry is out of that area. It can be potential from, the research point of view, but in fact, I mean, there are so many sources of potential probiotics that there is really no need to go there. So, first of all, these products are natural. We test safety completely. And then, how it can be consumed. Well, in this case, the probiotics were, of course, I mean, isolated, developed in fermentators, and then we concentrated, and we were using a dose of 10 billion per day. And the way that we were giving it to the participants in this specific study was in combination with a smoothie. But of course, I mean, perhaps the best way is to give it in a capsule, because in that way you don't need a big food matrix. But it can be combined, together with a capsule, perhaps with some dietary fibers or a smoothie. It's another very important point in this study is that we didn't change the dietary habits of the population, but in a real context, it's always important to provide dietary recommendations and increase physical exercise. I don't see any contraindication with any kind of food. In fact, there is no preference time of the day to take the product with the foods. So just in short, so this is a product that can easily be delivered in a capsule, and there is no problem with any interaction with any kind of food.
Thank you. That's very reassuring. I think some of the attendees may have felt that they could go out and buy a food that naturally has this product in it, but as you point out, the likelihood of getting an effective dose and the direct specificity in buying a food is not going to have the same effect.
No, certainly I will doubt that, because you will have to have, that concentration in that specific food, and it will have to be exactly, the before 20. So that's really unlikely. You really will have to supplement the food with a probiotic.
Absolutely. So your suggestion is that it's used in conjunction with quality diets, rather than and specific diets, rather than being a replacement for the diet, or necessarily expecting the diet to give the probiotics advantage.
Yeah, that's correct.
So when it comes to the interaction with prebiotics, now this study really shows a rather uncertain effect of the two together, some good and some where it doesn't appear to have any effect. But could you comment about the future of that? There's questions about that, and the importance of how, the potential of being able to put the right, if you like, the right food for the bacteria, the right environment for the bacteria to flourish through use of a prebiotic.
Yes, the study clearly shows that, using the factorial analysis, when you group the before 20. I mean, before 20 clearly shows an effect. Now, in many cases, this effect can be potentiated when you, of course, are adding a fiber into the media. So, and the reason is because, I mean, bifidobacterium, it's not like the probiotic enters into the gastrointestinal system and the probiotic is doing all the work. So you really need an environment where the probiotic is can be developed. You know, if it can be developed more, the effect is gonna be increased. I mean, if you take the probiotic alone, you certainly will prevent, you know, an increase in fat mass. But if you consume the probiotic together with a source of fibers, like, you know, recommending a good diet together with the administration of the probiotic, it will potentiate the effect of the probiotic. It happens with pretty much all probiotics existence. I mean, the addition of prebiotics always potentiates the colonization in the gastrointestinal system.
Yeah, the way I've heard it described is prebiotics, which are essentially fiber, and the one that's most commonly used is inulin, you know, that occurs naturally in chicory and stuff like that. Prebiotics are like scaffolding, you know, when you're making a house. They're what you get the construction to build around, and they really kind of set down the bones for it. And I can't agree more about the specificity part of all this. We know bariatric surgery really works when it comes to diabetes remission, and one of the mechanisms that's well recognized is GLP-1, which we saw demonstrated in the study. And there is a belief that some of the change that we see after surgery is probably mediated to some degree through changes in these communities, particularly through bile acid change of the microbiome. So this is accomplishing some of the same goals that we'd like to see around decreasing inflammation and increasing GLP-1. And John, you probably, you know, the Biggest Loser study showed that when people are dieting, they get permanent alteration in their GLP-1. So maybe this is a way to kind of help out in boosting GLP-1 and hopefully weight loss.
Yes, I think the potential for studies is enormous, and I think one of the things that comes out of this study is the type of population that was used was not severely obese. Indeed, there was no added lifestyle program, and today we would, you know, when we're studying this study was designed to look at efficacy and safety of a particular strain, but what we really need is real-world weight management programs using this with or without it. And I think, John, in the bariatric surgery world, we also need some specific studies, or at least some pilot work to look at effect in patients, not only just before bariatric surgery, but specifically after bariatric surgery. Would you like to comment on the type of information we need to move forward with using it in bariatric practice?
Well, I think it's going to be really useful from a lot of standpoints. I think there is a potential for some of the pre-op weight loss. You know, many programs are looking for people to lose, you know, anywhere from 5, even 10%. And with this, if this holds up, it could provide some of that weight loss for some of those patients before surgery. The other big one is, frankly, weight maintenance. And I think that was well pointed out, is as powerful an effect that bariatric surgery is, there is potential for weight regain in some patients. And the addition of this probiotic could potentially hold off on patients regaining their weight. I think, you know, the hallmark of any study is going to be if it's randomized or not. And so I think using this particular strain in some of the bariatric surgery patients would be ideal. But again, there's really not a whole lot of downside to trying this right now because it is very safe, as you saw mentioned there. But I think there's a lot of potential using it before and certainly after surgery. I'm super curious about its effect on vitamin levels because we know certain bacterial communities consume the same sort of vitamins and other micronutrients that we need. So I'm curious to see if that affects patients' micronutrient level, increasing it. And lastly, some of the GI quality of life. And John, you know this with all your work, with band and other surgeries, that some of these patients suffer from GI motility issues, and there's a pretty large body of literature around the use of probiotics and helping out with GI motility. I don't know if you have any thoughts about that, about probiotics and GI motility.
Yeah, look, I totally agree with you. I think we're learning about the specificity and effects of these specific probiotics, and I think one of the things that I'd like to see with regard to any new strain would be some testing in these patients, because for instance, we expect, and I think you've listed the advantages, the potential greater weight loss, the better nutrition, maybe the GI quality of life changes, and we certainly see that when we alter people's diets and so forth. But I think the other area is, the small potential for a change to irritate an aspect of the gut that might be prone to a particular strain, and that's why I think when utilizing a product like this early on in people, say, have had a gastric bypass for the first time, we need to watch carefully about the number of bowel actions and their gastrointestinal symptoms, and see if there's anything specific to gastric bypass patients or sleeve patients or indeed some of the malabsorptive procedures that are being done. It's unlikely, but we don't need to get any frights in this area.
No, it's a good point. I mean, that's why you always want to kind of follow up on this. And I think the recovery of the strain, I think, is really important too.
Yeah.
You take it and you see if it's still there, and you can observe that through doing some fecal samples. But it's exciting to see this kind of work come out, because there's so much promise around the Jeff Gordon's work, with the mice that were obese and the mice that were lean, and they took them and gave them the same sort of microbiome, and they became lean. It was just fascinating. And for a long time, we've been wondering if this will work in humans. So that's why I find, the results really intriguing, particularly for bariatric surgery patients, but anybody who's struggling with their weight.
Thanks, John. Dr. Abira, there's some perhaps specific questions coming in about B420. One is, does it need to be refrigerated? A second area is that could it work equally well as a capsule? And the third question is really, how different is it to other products that Bariatric Advantage already have? So I know you may not be, all over the other products, but if you could talk to us about some of the practicalities of using this of the 420.
Yeah, well, certainly. I mean, this product is very stable at normal temperature, ambient temperature. So we have run several tests. During the production, we normally test it at 40 degrees, then 20 degrees. I'm talking about Celsius. I'm more familiar with Celsius here in Europe, and then even higher temperatures. And the product is really stable. Certainly, I mean, the best way to deliver this product, just to guarantee the concentration, is through capsules. And probably everybody already knows, Bariatric Advantage is selling this under the name of Advantage Control, and that's probably the best source to get B420 nowadays in the U.S. Besides that, I wanted to comment something about what Dr. John Morton was saying about getting fecal samples and then testing effectively the probiotic is there. In our studies, we have developed two PCR methods, and we normally, take fecal samples from the participants in the studies in order to check that they effectively have consumed the product during the treatment. Is one of the several ways to confirm the per protocol population. So what we do is we request fecal samples, and then in our labs we have already determined the primers in the for qPCR method, and then we effectively, we are able really to see the levels of concentration of B420 in the feces, among the trillions of bacteria that there are there. So we really, can really relate the effect to the concentration of the probiotic in feces. And it also is very beneficial because we have seen changes in the microbiota composition, reducing, harmful bacteria as comparison to the increase in B420 concentration. So I think that, this is of course, very important in the normal population, but now thinking about bariatric surgery patients, or patients who have passed through bariatric surgery, I am not an expert in that area at all, but I can imagine that, after one of those surgeries, the microflora will be greatly affected. So by giving this probiotic, I am almost sure that, the microbiota will be balanced in relatively short term, besides helping in the control of weight regain.
Thanks, Dr. Rivera. I think there's the other point there is related to the specificity again. You're able to identify specifically your strain, and indeed being able to do that reassures us that that's happening in our patients. And I think we don't need to go and look specifically in normal patients, but I suppose there's that question: could bariatric surgery patients be different? And we can think about that, but for the general patient, your studies on dose and etc. are reassuring that we are getting the bacteria where it should be. Are there any contraindications to use of this probiotic, and are there any tolerance issues or problems with immunity that are occurring? So, are there patients we wouldn't use this probiotic on, or are there do we see a development of tolerance or immunity to the particular probiotic?
No, we don't have any evidence that there is any contraindication with this probiotic. Bifidobacterium group, in general, are extremely well tolerated and are beneficial in the colonization, in the large intestine. So from that point of view, I wouldn't be concerned at all. Of course, if you are consuming an antibiotic, you probably will clean up all the microbiota anyway. But again, this is a probiotic that will be easily restored. So even after an episode of, for instance, infection, where you have affected, but not only this specific probiotic, but all the microbiota, the administration of B420 will restore the balance in relatively short term.
Yeah, so this is a very cool way of being able to give something that's specific and therapeutic that doesn't cause allergies and other things, and have specific. So it's a bit like a specificity, a pharmacological specificity for the gut, but it protects the person from those things. I asked the question because it's been coming up on the panel here. We only have a couple of minutes, or in fact a minute to go. So I have one question that's come up here: is are you comparing this to any other bacteria as probiotics for weight loss? And I'd like at the same time if you would summarize any key points you want to tell us about take-home messages from this program.
Well,
Dr. Beer,
yeah, sure. Well, first of all, that is pretty much one of the first probiotics with proven efficacy in humans to regulate body weight and body fat mass. We have evidence showing that has beneficial impact in the intestinal barrier function, that regulates energy intake, and certainly positively affects body composition by reducing fat mass.
Thank you very much. That's I think you've given some tremendous detail. John Morton, would you like to any final comments?
Like we've said already, I think it's an exciting new development. As Dr. Barra said, there have been very few studies in humans at all, and so this is very compelling. The trial was rigorous, as you heard earlier. They did recover the strain, meaning they got what was intended. It's almost like Koch's postulates. You have to find the organism that causes the disease and recover it, and see if you can get it to work again. In this case, it's not disease but cure, hopefully, or at least maintenance or improvement. And I think there's quite a bright future available here, particularly around maintenance. That's really where I think it's going to make a big difference. I congratulate Dr. Barra on all his work and Bariatric Advantage for providing this for people to use. And I think it's available now, as I understand.
So it's a very exciting program. I want to thank my guests, Alvin Abira and John Morton, for giving very detailed presentations and expectations, and we look forward to seeing how this runs in your practices, and look forward to seeing you again on future webinars through Bariatric Advantage. Thank you.
Thank you very much, Dr. Nixon. Thank you, Dr. Morton, and everybody.
Thank you.